there are so many conditions and diseases that can lead to SIBO. I mean, like diabetes, hypothyroid, and on inflammatory bowel disease, because it can cause strictures, cancer with tumors. The list is huge.
Dr. Siebecker, thank you for joining us today. So excited to talk all about small intestinal bacterial overgrowth. It is a really hot topic that a lot of people are talking about in alternative and holistic wellness. And you are a wealth of information. And for those that don't know, we met this quarter. I'm in advanced gastroenterology, and you have so much knowledge to share about this. So I had to have you on to share this information with my audience. So before we get started, can you tell me a little bit about yourself, where you're at right now in your practice, what you're doing, and then we'll get started.
Yeah. So as you mentioned, I teach advanced gastroenterology at the college, and I practiced specializing in SIBO ever since 2010. And what that means is that's the only thing I treat. So I only see patients with SIBO. So everyone, every day has SIBO. So it wasn't after just a fairly short time, I accumulated a lot of information. And I joined forces with one of your other teachers and my dear colleague, Dr. Sandberg Lewis, gastroenterology professor for a very, very long time. And together we sort of went on a mission to raise awareness about SIBO. We sort of found out about it around the same time. And so we've done all sorts of things to help raise awareness. And the reason we wanted to raise awareness is because as naturopathic physicians, we were seeing people that we couldn't get better who had, there were typical diagnoses that we would be thinking of that weren't working, like yeast overgrowth or candida or parasitic infection, when we couldn't figure out what was going on with gastrointestinal problems. And when we found out about SIBO, it turned out a large majority of those people had that and responded to this treatment when they didn't respond to the other treatments. So we sort of want to let everybody know about it because there'd been quite a lot of information put out about it, but not everybody knew about it. So anyway, we did all sorts of things. Like I have a website, free educational website, SIBO Info. And we started the first ever symposium or conference just on SIBO and wrote articles and just did all sorts of things like that. So that's
amazing. So definitely making that information more accessible because there's so much information out there. And I think people are a little confused. They don't know how to treat it, how to go about it. What is SIBO? What is not SIBO? What are some of these common symptoms that someone may be experiencing that would maybe lead you to suspect that there is an issue with SIBO? And then what potential downstream consequences are there if there is this underlying SIBO that goes untreated?
Sure. So the symptoms are the same as IBS, irritable bowel syndrome, which is abdominal bloating. That's the hallmark symptom, actually. When the belly, the belly swells out. There's also a feeling that's like of swelling, and both are part of it. Constipation, diarrhea, or a mixture of the two. Abdominal pain or just discomfort. Those are the core symptoms. But then we also have things like excessive burping and farting as the gas exits, nausea, acid reflux, fatigue, anxiety is very common, actually. Sometimes depression, sometimes brain fog, but anxiety is actually more common and is actually caused by the condition. So that's, these are some of the downstream issues. IBS is one of the downstream issues. Other things that can happen are things like lactose intolerance, fructose intolerance, other food intolerances, anemia, or just like chronic low ferritin, which is not full anemia yet, and leaky gut syndrome. Leaky gut syndrome or increased increased intestinal permeability, is part of a triad that leads to autoimmunity. So many people have autoimmune conditions like Hashimoto's hypothyroid. Leaky gut is considered one of the three underpinnings of that. So leaky gut's important. And SIBO can cause leaky gut. It's important because it could predispose a person who might have a genetic tendency towards a certain autoimmune disease to allow it to more readily develop.
Yeah, I like to tell my audience that having increased intestinal permeability is basically a prerequisite to autoimmune, but you have to have that genetic predisposition. And typically there's that triggering factor that kind of just is that total body burden, that rain barrel starts to overfill. And then we have that new diagnosis. And so there's so much connection with the gut, and SIBO being one of that part. So with small intestinal bacterial overgrowth, you mentioned that there can be all of these intolerances to food. Is there actual damage to the small intestine? And then also I'd love for you to clarify, like, where exactly is this overgrowth of bacteria? Is it pathogenic bacteria? Where is this happening in the digestive system?
Okay, let's do that one first. So yes, there's damage occurring to the small intestine tissue. The overgrowth is of normal commensal bacteria, which is surprising for a lot of people to hear, because I think most people who just have a general sense of things that can go wrong in the, abdomen or gastrointestinal tract, think of bad bacteria, good
Yeah.
bacteria and bad bacteria, good bacteria being probiotics. And this isn't really either. They're not probiotics. They're not bad pathogenic bacteria. They're just normal bacteria that live normally down in the large intestine or maybe in the mouth. And they just get into the wrong location and multiply. And so it's a combination of the location as well as the amount of the bacteria. That organ is not supposed to have a lot of bacteria like the large intestine is. Like,
Yeah.
it's fine to have lots down there. So that's the issue there. Now, what was the first part of the question? It was something about,
Yeah, so there's damage actually. So those intolerances that you're talking about. So
yeah.
there's damage to the microvilli, so you can't properly absorb, or is there an issue with you breaking down those certain sugars? I think was the question.
Yeah. Okay. Yeah. So it's true. There is damage. So sometimes people do not have the enzymes necessary to break down the sugars, basically. The enzymes sit along the lining of the small intestine and can get damaged by the overgrowth of bacteria. They actually do things like secrete their own enzymes, their own digestive enzymes that break down our digestive enzymes. So they do all kinds of things. There are, I think, cases of people who are not experiencing a lot of damage along the lining of the small intestine. They still can malabsorb all these sugars,
Mhm.
carbohydrates in particular. And let me explain that in a sec. Just by the fact that the bacteria are there. So even if there isn't damage, although we think most of the time there is, the bacteria are sort of just like sitting there waiting for that food
Yeah.
way up high, and they can grab onto it. And when they eat, it's called fermentation, at least of carbohydrates, and they secrete gas. And those gases are very active in us. They can cause the swelling of the bloating. They can actually cause bowel movement changes, speed up or slow down motility, do all kinds of things. They can induce pain. So the issue is really, in terms of the foods, it's carbohydrates, because that's what bacteria eat. That's
Mhm.
their primary food.
Yeah.
So if they get a hold of that food, and carbohydrates are just all kinds of foods, vegetables, fruits, all kinds of healthy things, along with sweets and sugars,
Mhm.
grains, nuts, seeds, the lactose in milk, etc. So when they get a hold of that, they ferment it into gas, and that causes all kinds of problems.
So this is all coming from the bacteria or that overgrowth of bacteria because our human cells, they can't produce gas. Is that right?
Right. The bacteria are secreting two main gases that we can't secrete,
Okay.
hydrogen and methane. And technically, it's archaea that make the methane gas. But as convention, a lot of people just say bacteria. A lot of articles use that. And we just know it's archaea. They're very similar to bacteria, extremely similar,
Mhm.
but a different classification of life. However, one last thing is that we do make hydrogen sulfide gas. So these are the three gases, and they divide SIBO into several types. We do make that gas, I mean, but it's about the amount in that situation. It's kind of always about the amount of the gas. And if it gets in excess, that gas is actually toxic. In normal amounts, it's extremely healing. So, as all things, there's the balance.
Okay. So the gases then, those are affecting motility, as you said. What are you going to typically see with somebody that has more methane producing bacteria versus hydrogen producing bacteria, or maybe that's hydrogen sulfide? Is there any clinical clues that you see that may lead you to believe that it may be this type of bacteria that predominates? And then how would you test for that?
Great. So hydrogen and hydrogen sulfide are more so correlated with diarrhea. Methane is a cause of constipation. We know that. It's called a gasotransmitter. It actually acts on the nervous system in the small intestine to create slowing of motility. It also can create a little bit of reverse hypermotility, like this sort of motion.
Mhm.
And certainly a motion that just doesn't move down.
Yeah.
But because sometimes it has this little backward motion, it can lead to nausea, belching, and acid reflux. So this is not always, but
Mhm.
methane, first off, constipation, maybe nausea, acid reflux, and burping. When we come to, and then of course they all have all of those original symptoms I described, the
Mhm.
bloating, etc. But when we come to hydrogen sulfide, there are a few other symptoms, things like tingling or numbness in the hands, feet, fingers, and toes,
Mhm.
or possibly a smell to breath, burps, or farts that's sulfurous.
Mhm.
That's not as common. Body pain, like almost more like muscular body pain, kind of like a fibromyalgia type
Mhm.
body pain, and irritable bladder symptoms. So frequent urination or a sense of urgency, maybe without good flow, that sort of thing. It's kind of the interstitial cystitis type
Yeah.
symptoms. So these are some of the things. There are some other things, but with hydrogen sulfide, you get some other symptoms that often affect the nerves because it's toxic to nerves in excess.
Mhm.
So now hydrogen, just is associated with diarrhea and the typical symptoms. So then you asked, how could we test for it?
Yeah.
So we test by the breath test predominantly. There's a few tests we can use, but this is our main one.
Mhm.
And it's tests for hydrogen and methane gas currently, because hydrogen sulfide gas technology for testing has not been released commercially yet. It's being used in research, but it's not quite available yet. We're all looking forward to it. So we test for those gases, and this is called the SIBO breath test. And there's a couple of forms. There's a glucose breath test and a lactulose breath test. And most people in the US tend to use lactulose because by the way, these are sugars that we drink at the beginning of the test that are meant to feed the bacteria
Mhm.
so that they'll produce gas. So it's a challenge test. And then we'll see the gas coming out because it diffuses across from the small intestine into the blood, goes to the lungs, we breathe it out, and we can sample that. And so we'll see it. And we know it's bacteria because humans don't make those gases, as you mentioned.
Yeah.
So lactulose and glucose are the sort of substrates. That's
Mhm.
one of the types of tests. The other thing that we need to know is how long the test is being done for. And I always recommend a 3-hour test. And the reason being is certainly until hydrogen sulfide testing comes out, we need a 3-hour lactulose test to get a sense if somebody has hydrogen sulfide on the test. There'll be a distinct pattern that's called a flat line. And specifically, we won't see hydrogen gas rise in the 3rd hour, which normally we would, because normally the 3rd hour represents the large intestine where we have a lot of bacteria and they
Yeah.
should be making some gas. So that's a little bit technical. Not everybody needs to know how to interpret, but
Yeah.
that's basically my recommendation is a 3-hour lactulose breath test. And it can be sometimes hard to come by that. Many doctors don't have education on this and they just go with whatever company is being carried in their
Mhm.
office, and it might not be a 3-hour lactulose. Patients themselves can order glucose breath tests, and also there are 2 labs that really it's all down to one now that offer direct patient ordering of lactulose breath tests,
Okay.
and you can see that on my website underneath resources testing.
Awesome. Yeah, I was going to ask that. What is the accessibility to a lot of these labs? Because a lot of people, maybe they don't have access to an integrative or holistic doctor that may be well trained in SIBO and understanding more of these complexities and nuances. So is this covered by insurance? You mentioned that there's those resources there. Can you just share a little bit more about that too?
Yeah, many people have it covered by insurance, thankfully, but not all plans in the US. Yes, you can order your own glucose or lactulose breath test. You can see those labs you can order from on my website under resources testing. The 2 companies that offer the direct patient ordering of lactulose breath tests, they now all are coming from Genova Labs.
Okay.
But it's through, I think, True Health and Direct are the labs,
Okay.
and that you have to order through. But Genova doesn't offer a full 3-hour 10-tube test. I don't know why, but this truncates our information we need for the 3rd hour for distinguishing hydrogen sulfide. But there just is no other option currently available if a patient has to order it themselves. And I mention this because I have had several, I teach physicians postgraduately, and I've had a lot of physicians tell me that they're having trouble. They're thinking their patients might be hydrogen sulfide when they have this 8-tube test instead of 10 tubes. We've had a lot of trouble doing proper interpretation. We really need, for best assessment, 10 tubes.
Okay, that's good to know.
But you do what you can.
Yeah,
And if you have nothing else available, you just get a glucose and take it from there.
Yeah, so it's important to test. And I think what you always talk about, like you want to test, not guess, so you know exactly what you're treating. Is that right?
It's so important
Yeah.
because the symptoms, the general symptoms I described, I mean, anyone listening is probably experienced them, right? So, I mean, how many conditions have those symptoms?
Yeah.
It's 35 or 40, maybe 45. And so we call this the differential diagnosis is huge. So you cannot know what somebody has just because they said they have bloating and diarrhea. It could be 45 different things, So you are really guessing. So a test is needed to diagnose it. And the key thing with SIBO is to actually diagnose it. You need a test and the symptoms. You can't have one or the other.
Okay.
Actually, I didn't mention that there's another test that's, even though it's been out many years, it hasn't come into common awareness, and it's a blood test. And it's a good screening test, I think, in the primary care setting for IBS, because, and we'll get into this in a minute, I'm sure, but most or the majority of SIBO is thought to be caused by food poisoning. And that particular cause of SIBO has another name. It's called post-infectious IBS. And that can be checked for with a blood test. And I generally call it the IBS blood test, but it goes under names like IBS Smart. That's the most updated version, IBS Check, and there's a couple of others. And that's pretty simple. And again, should be covered by insurance. I don't know everybody's plan, and most primary care physicians haven't even heard of it, which is a shame. This test can actually distinguish between inflammatory bowel disease, which is much more serious than irritable bowel syndrome. So if this test is positive, it means you have IBS and not IBD, at least with like 98% probability, and which is very high. And then you would likely go on to do a breath test, because we use that information in picking our treatment and understanding our prognosis. But this is a great screening test.
Amazing. So I did want to follow up on that, but in terms of the symptoms, you talked about, the abdominal distension, gas, bloating, diarrhea, constipation. There's a mix. Do you get to have all three of those? I mean, yes, you can test, but like if someone just has bloating, but they don't have diarrhea and they don't have constipation, could they still have SIBO? Or
that is such a great question. By the way, you always have great questions, which I'm sure your audience knows. You don't have to have all the symptoms, but the first thing that you want to think about is, might a person actually have that symptom if they weren't doing something that they now can't remember that they're doing? So for instance, if somebody has had constipation for a lot of their life, they may have figured out if they drink, 2 cups of strong black coffee in the morning and, do a few other things. I'm just making this up. Maybe it's like they learned magnesium can help, and maybe they don't take a massive dose, but along with the coffee, they take 3 magnesium throughout the day, and they just think of it as it's good for their bones or something. And they don't even remember that this actually helps them with their constipation. So I just would want to say that is, try to think back. Are there things that you do that make your other symptoms be well controlled and even gone? But let's say somebody really has nothing but one symptom. It is possible. Those cases are more rare. Those are definitely more rare. Usually you have 2, if not 3 symptoms, and honestly, more like 4 or 5.
Okay. So there's definitely a bigger picture clinically in terms of the symptoms that person is experiencing.
Yeah, usually.
So following up then, just talking about the post-infectious IBS, what are, so you talked about impaired motility, you talked about either constipation or diarrhea, how it's speeding up that process that it is going through the GI tract. What are some of these physiologic root causes and or risk factors that would make someone more predisposed to SIBO? I mean, in the naturopathic world, we're always talking about the terrain, and it's terrain dependent. So what are some of these things that protect us from getting SIBO, and how do these alterations in these protectins make us more susceptible to developing SIBO?
Right. So we have these wonderful protections in place because normally we don't have an overgrowth of bacteria in the small intestine. And our body does things like it makes hydrochloric acid in the stomach, which kills bacteria. We have bile, which is released into the top of the small intestine, which is also very killing. We have the normal anatomy of the intestines, which is meant for things to flow through it, down, through, and out. We have the motility, and the anatomy and the motility are probably the most important factors. The motility, this is of the small intestine. And unless you've been educated on SIBO, you wouldn't know that the small intestine has its own special motility that's meant to actually clean out bacteria, as well as any cellular debris or any kind of leftover mess from the meal, so to speak.
Yeah.
And it's called the migrating motor complex. And this occurs after meals. So basically between meals, if you're not snacking, and overnight when we're sleeping and we're fasting. So it occurs during fasting. And it's very, very important. And then there's other things like the ileocecal valve at the bottom of the small intestine kind of helps protect so all the bacteria in the below in the large intestine don't come back up.
Okay.
And these are some of the main factors. We also have enzymes. Our digestive enzymes help protect against, they can actually kill bacteria too. So, and our immune system, also our immune system. And particularly there's a gut associated immune system called the GALT, and we have our systemic immune system. So all of these factors are in play. And so what the risk factors do, the causes of SIBO, is they turn those off. And the two most important to be messed with or turned off are the migrating motor complex and the normal anatomy. So the post-infectious IBS, the food poisoning, that one turns off the migrating motor complex. And I can explain how that does it. But just as an example of structural issues, probably the most common one there would be adhesions, which are like scar bands that can form within the abdomen after surgery, after an injury, after, like sports accident or a blow, a car accident. And like I said, surgery is very common. And these could do something where they maybe push down and basically obstruct the flow of materials through the small intestine. So anything that could cause some kind of partial obstruction, and adhesions are just an example, but there's all sorts of things that can do that. And that would then cause bacteria to back up behind that area and overgrow. So just back to the post-infectious IBS one briefly, the way this happens is food poisoning is caused by actually pathogenic bad bacteria, as people think of it. And they all have the same toxin, and that toxin looks similar to a protein on our small intestine nerves called vinculin. And so we can be created an autoimmune situation here. We can become reactive against, decide to target the protein on our nerves, basically target our nerves in the small intestine. And when we do that, there's this particular nerves, the interstitial cells of Cajal.
Yeah.
They are responsible for the migrating motor complex, actually. So we then have less of them, and then we have less of the migrating motor complex waves. And after a certain amount of that happens, we reach a threshold where the bacteria can overgrow. Stagnation, basically.
Yeah.
It's basically, there's no flow. So because bacteria are coming inside of us through our mouth, our nose, swallowing all the time.
Yeah. So basically there's this damage to the migrating motor complex, which sweeps that bacteria and moves everything through the small intestines into the colon. And if you have damage to that, you can get that overgrowth or stagnation of bacteria in that area. And so I think that was very interesting to me when you first mentioned that, because I just thought about, I think of gastroenteritis as just very acute in terms of like bacterial gastroenteritis, but it's actually a long-term consequence of that one acute event that can lead to an autoimmune-driven SIBO process.
This is one of the most astonishing things for me to learn. Most of us think of it as a nuisance. I mean, a horrible nuisance. I mean, you feel like you're going to die when it happens, and you wish that you would, because it's so terrible. And then, not to make light of it, in other countries, this is still a leading cause of death, particularly for children. But in the U.S. And many modernized countries, people don't typically die from it, thankfully. And we're just, it's here and gone. But we do not realize it can go on to lead to a lifetime of chronic IBS, basically, through this mechanism, which is SIBO, which is just horrendous.
So there's a blood test then that you were talking about that actually looks at autoantibodies to that vinculin protein. Is that right?
Vinculin. Yep. And then the toxin that the bacteria secrete,
Okay.
which is called CDTB. So that's it. That's that test.
And what blew my mind in one of our classes was when we were talking about appendectomies or appendicitis and the C. jejuni, which is, what did you say was 51% or something?
Or someone very close to 50%. Maybe it was like 48. I can't remember, but basically.
We haven't known what causes people to have appendicitis. And it sounds like a bacterial derived origin type of infection.
Yep, this is the work of Dr. Pimentel, as is the post-infectious work. He's the leading researcher in SIBO, and he just came out with this last spring. Mind-blowing. So now we know at least half of cases of appendicitis are actually caused by food poisoning, basically. Campylobacter jejuni, that's a food poisoning bacteria.
Yeah.
Unbelievable. And then, of course, can lead to SIBO. There's all kinds of ways that can lead to SIBO. It could be the food poisoning. It could be the surgery. It could just be adhesions from the inflammation of that occurring. Maybe somebody had appendicitis, didn't go to the hospital. And, we didn't mention all the other diseases, but there are so many conditions and diseases that can lead to SIBO. I mean, like diabetes, hypothyroid, and inflammatory bowel disease, because it can cause strictures, cancer with tumors. The list is huge. It's huge.
Is that anything that's going to slow down motility? Because I think about some of those things like hypothyroidism and diabetes and like the impact it has on motility. So there's
anything that slows that migrating motor complex, and like opioid narcotics, right? Okay. And then anything that inhibits the flow in the structure, like inflammatory bowel disease and cancer. Tumors can occlude strictures from inflammatory bowel disease.
So when you talked about some of these risk factors too, and you talked about, the terrain and how we have this hydrochloric acid, we have pancreatic enzymes, we have bile, we have the migrating motor complex. So, there is this infectious-based cause that are impairing our ability to protect ourselves from getting SIBO. But, we also have these other things like antibiotics, and we have PPIs that are used as standard of care to treat people with maybe high stomach acid, or there's an infection. And, we live really stressed lifestyles now. Are there some other things too that you can kind of talk about, and like why people may be producing lower stomach acid, or what is the point of, obviously medications play a time and place, but what could happen long-term if we're not actually addressing these root causes and we're just banning some of these medications?
Right. Well, as you mentioned, proton pump inhibitors are, I think, the third most commonly prescribed drug. I don't know. I can't remember exactly. I'm sure that statistic changes a little bit in the world. And they turn off hydrochloric acid production. So they're only meant to be used short term. They're a risk factor for SIBO. In and of themselves, it might not be enough. That's what the research tends to show. You then would additionally need something that's going to slow your motility or cause some sort of obstruction. But if you have, maybe you have a little bit of something that's slowing your motility, and then you have the proton pump inhibitor together, that could do it. Stress, as you mentioned, that turns off hydrochloric acid production. It turns off bile release, and it slows the motility. It turns off the migrating motor complex. It also decreases your immune system for a significant amount of time. So this is a very serious thing in our life, and we can't get stressed out about it. because that's the whole point, right? So I try to bring that down into bite sizes and talk about two things, and that's rushing, because that's fight or flight, right? And so try not to rush. Just try to live at a pace, slow your pace a little bit more. And then second is worrying, because that's very ubiquitous for most people. We worry about just everything that's coming in our day, and many people have trouble sleeping. They're just worrying about everything. So that's very difficult to control. And I'll leave it to all of you to decide what to do about it. You're all smart people. I'm just going to bring your attention to it. We do need to decrease our worrying. I'm saying this as a doctor to all of you. You have to decrease your worrying.
And in medical school, it's just like stress is at an all-time high.
It's unbelievable.
It's like trying to be more mindful, sit down and really savor that food and engender that cephalic phase of digestion. So we're getting adequate pancreatic secretions and secretion of different enzymes in the oral cavity, so we can better break down carbohydrates, chew our food, that mechanical chewing. Just take time. There was this was in like BuzzFeed. I think I saw like some statistics saying like it was like 70% of Americans eat their food between jobs or like on the go when they're in the car. And so you're just like think about
Or like at their desk, at their computer.
yeah. So
I don't recommend that. Yeah, this is all these things you mentioned. Try to chew well, think about the food. Also, gratitude before meals is important, whether that's grace or your own. Just take a breath,
yeah,
1 to 3 deep breaths. Switch you from sympathetic into parasympathetic, which is what we need when we're eating. Anything you can do to help yourself switch into parasympathetic, a little bit of a walk, swing your arms,
yeah,
just take a moment, go out and if you can, if you're in an area where you can, depends on if it's winter or whatever, look at some aspect of nature, like looking at insects is good, looking at, like bees.
yeah,
They switch you into parasympathetic. So that's
yeah,
what we need. And all of these things that you've mentioned, I think your original question was, look, we've got a lot of assaults coming at us and we have a lot of risk factors, diseases that can occur. So basically we need to do what we can to protect our protections.
yeah.
So to foster our hydrochloric acid, our immune system, calm the stress, try not to take proton pump inhibitors. You also mentioned antibiotics. We had seen antibiotics seem to lead to SIBO clinically. We had seen this, and it's a bit of a catch-22 because we also use antibiotics of different types to treat it,
Yeah.
which we'll get to. But what we finally saw was just at least a preliminary study showing that antibiotics can slow the stomach motility. And when the stomach motility slows, there's one of the migrating motor complex waves originates in the stomach. So when the stomach motility slows, typically that leads to SIBO. So, we just didn't know why. And, the general concept that most everyone has is, they disturb the microflora. But how does that actually lead to SIBO was always our question.
Yeah.
Because you really need to have one of these things, like an obstruction or the motility. And now we see there's a link to that.
It's multifactorial, as you were talking about. Do we know in particular what kind of antibiotics would be disrupting that?
No, the study was so preliminary. There wasn't even how or anything, but at least we're starting to be like, maybe that's why.
Listen up a little bit. So you talked about, okay, so you have to have the clinical suspicion, you have the symptoms, you do the testing in terms of the breath testing, we have the blood tests. Really trendy now, and I'm hearing a lot on social media and stuff like that, are some of these stool tests like the biome test. You also have some of these really interesting urine organic acid tests and stuff like that will show you metabolites of bacteria and yeast and stuff like that. Can you use some of these to diagnose SIBO, or is it really just those breath tests that you can rely on?
Technically, you cannot use any of those to diagnose SIBO. The makers of those tests will tell you the same.
Okay.
However, the urine organic acid test can give you an indication, because if you see metabolites that indicate bacterial overgrowth, it could be the small intestine or it could be the large intestine. The issue with that test is they can't distinguish between the two. So unfortunate. But sometimes we need to use that test if a patient is very, very young and can't perform the breath test. So it's something that, could be an indicator. The concern there is when people who don't have access to the test, because I didn't mention lactulose is a prescription item in our country. And so many physicians, or actually they're not physicians, they're practitioners who don't have prescribing license will have used the organic acid test, unfortunately, and diagnose somebody with SIBO, and that is inappropriate. You can't diagnose. Stool tests are amazing, and they tell us about the large intestine. There's a few things they can reflect about SIBO, particularly fat malabsorption. Because that's a sign of SIBO, but they don't diagnose SIBO because they're assessing the large intestine. And in fact, they are actually only assessing the last portion of the large intestine, the descending colon. So it's quite limited what you're testing, and they don't diagnose SIBO.
Got it. That was very helpful. So you've gone through testing and you've, come to the conclusion that your working diagnosis is this person has SIBO. What are the different tools you have in your toolkit from like a naturopathic perspective that you would treat someone with SIBO? And again, I'm sure it's dependent on the specific type of bacteria that you are treating. You mentioned antibiotics, but is that all that there is?
Right. So as particularly as naturopathic physicians, we have open full licensure, at least in the states that you and I are in.
Yeah.
So that means we get to use everything. So what we have is we have pharmaceutical antibiotics, herbal antibiotics, and we also use elemental diet. And there are also some supplements, depending upon the type, that can be used. But basically, those are our three 3 tools. And what we find is that sometimes people respond to just one of those. And so it really helps when you are seeing a practitioner who has access to all of them, or
Yeah.
who at least will be willing to inform you about all of them, which is hard because traditional MDs often are not very open or favorable towards herbs. And many naturopaths or alternative practitioners are totally against pharmaceutical antibiotics.
Mhm.
And often neither of them know about elemental diet, although that one is used by everybody. So
Can you tell
do you
us a
want me
little
to go
bit more
through?
about elemental
Yeah.
diet?
Yeah. Oh, about elemental diet? Sure. Elemental diet is a powder that you mix with water and turn it into a medical drink. And it's all the nutrients in pre-digested form. So it's vitamins and minerals, electrolytes, but then it has protein as amino acids, it has oil, and it has your carbohydrates as simple or very small sugars like glucose. And because of this, it can absorb quickly into the body within the first probably 2 feet. And this then, it goes so quick, it doesn't get a chance to feed the bacteria. And so then this starves the bacteria,
Oh,
hopefully. And that does seem to be what happens. It has a very high effectiveness rate. In fact, so do all of the treatments for SIBO. They're anywhere between about 84 to like 91, 92% effectiveness in studies, which is remarkable,
amazing.
actually.
Yeah.
Yeah, really, really amazing. So that's elemental diet. And do you want me to discuss the other two or
Yeah,
more on
I love
elemental
this.
diet?
Like, what are, the antibiotics? What are we typically using? I know there's a lot of discussion and I would say fear, especially kind of in that holistic community around antibiotics because the long-term disruption of the gut microbiome that people are worried about. So how, when we're talking about some of these antibiotics like rifaximin, is that disrupting the gut microbiome? And then like, how would that be advantageous or a disadvantage compared to some of these herbal antibiotics?
Right. So I can just answer that last one first, which is that the all three of these methods have the same effectiveness rate. And it's interesting to see the bias that people come from. They want to immediately assume one type works better than another. And that is just absolutely not the case. Thankfully, they're all equal. So it's
Yeah.
really just a matter of pros and cons within each of them. So rifaximin, as you mentioned, is the primary pharmaceutical antibiotic. And it's very special. It is not a typical antibiotic at all. So luckily, if we are using that one, those of us who are afraid or concerned, we don't need to be because it actually increases lactobacillus and bifidus in the large intestine when you take it. It's astonishing. It has eubiotic properties. It's called an antibiotic with eubiotic properties. It's anti-inflammatory. It doesn't cause yeast overgrowth. It also doesn't absorb into the body. It stays in the intestine and does its work there. So it's called luminal in the lumen. So it just has all these amazing properties. It doesn't get antibiotic resistance, and it goes on and on and on. You almost can't believe it when you read all of it. It's very special.
True.
Yeah. So fortunately, that's the main one we use. Now, when that is for hydrogen type SIBO. When you move over to methane type SIBO, which by the way, I didn't mention, has a proposed name change. Instead of methane SIBO, it's being proposed to be called intestinal methanogen overgrowth. Methanogen overgrowth or EMO. Anyway, yeah, which is so cute. Anyway, when you have this overgrowth, there are both hydrogen producing and methane producing archaea overgrown. You need to add another antibiotic. And this is the same for herbals, which I'll get to in a minute. So you need double therapy. So now you would have to add either neomycin or metronidazole, which is also called Flagyl. Neomycin and metronidazole are typical antibiotics. So unfortunately, if you have that type, if you have the constipation type, you don't get the chance to just use rifaximin and have none of the issues. So neomycin also does not absorb into the body, but it does affect the large intestine microflora. Now, Dr. Pimentel says in his experience and from his studies, it doesn't affect it as much as something like metronidazole. It's similar on the spectrum towards rifaximin. Doesn't mean you won't have negative side effects, though you can, like nausea or headache or any of the things you can have. Rifaximin tends to not have that at all. In fact, side effects are equal to when they just give sugar pills, so to speak, placebo. So metronidazole does absorb into the whole body, and so all of your typical problems and side effects can occur. I will say that in all the years I've given it, I see it being generally well tolerated, and what I mean by that is that if you go online and read about metronidazole, you just see these horror stories. I don't see that. And I wonder if it's because it's a very appropriate medicine for the circumstance. So maybe I don't know, I'm making this up, but maybe it just sort of goes to where it's needed and does its job and doesn't mess with everything else. I don't know.
Yeah.
Who knows? Now, let's switch to herbal for a minute.
Yeah.
With herbal antibiotics, there are several that we tend to use if we're doing an approach that is single antibiotics. So I tend to like that approach. So there's berberine-containing herbs like golden seal, Oregon grape, coptis, things like that. Then we have oregano oil, and neem, N-E-E-M, neem. And those are all effective, like rifaximin, against the hydrogen-producing bacteria. Then, if a person has methane, we have to add in allicin, which is an ingredient that comes from garlic, or atrantil is another product that has been shown to be effective against methanogens. Works a little different. That has peppermint leaf, quebracho bark, and conker tree. So those are effective against the archaea. They are not bacteria that they're working on. So we need something different there. That's why we need the neomycin or metronidazole or the allicin or atrantil. So what we do if we're doing a single herbal method in comparison to a combination product, which I'll describe in a minute, is we use like berberine plus allicin, or oregano plus allicin, or neem plus allicin. So we just use 2 herbs, kind of like we used 2 antibiotics, 2 pharmaceutical antibiotics. Now, another method is to use a combination herbal antibiotic, really herbal antimicrobial product. And this is what a lot of practitioners like to do. And they have herbs in there that are effective against yeast overgrowth, also viral overgrowth, and parasites, parasitic overgrowth. So it's like everything but the kitchen sink. Some of these formulas are massive, some are smaller. I don't tend to do that because I see a lot of people get resistant to the herbs that are given, also to the antibiotics. And a key thing in SIBO treatment is that because it is a colonization, basically, it's an overgrowth and not technically an infection. It's not like in 2 weeks it's gone. Now, for some people it is. There's a portion of people that it is, but the majority it's not. And we tend to have to keep treating until we get that overgrowth down and we see effects. And so we need multiple treatments, like 2, 3, 4. And so these different rounds have to occur. And so I tend to see people developing clinical resistance or tolerance called tachyphylaxis to these treatments. And so I don't want to give a product that has every possible killing agent in the herbal spectrum at one go, because then what am I supposed to use next?
Yeah.
And so that's why, and also a lot of people with SIBO, they have food intolerances, as we know, but they also tend to be, in general as a group, sensitive to anything that comes in. So like to supplements, and they're just generally sensitive. And so often they'll have sensitive reactions. And if I just am using 2 products, I can easily identify what is causing the problem.
Yeah.
So that's it.
So you also talked about some people will have these sensitivities, and you mentioned this earlier in our discussion as well, that a lot of these are to these fermentable carbohydrates, these fructooligosaccharides, and you mentioned allicin, which is found in garlic. So do these people, like, would they also react to that allicin? Is it not because it's not having that prebiotic in there and they've taken that out? What have you seen in as far as the allicin?
So important, because people are so afraid of it.
Yeah.
Garlic is one of the least well-tolerated foods in SIBO patients. Now, some people do tolerate it because the food tolerances are very individual, but it has in it FOS, which is the prebiotic, and some other very fermentable ingredients. And the allicin, the purified allicin, does not seem to have that in there. I don't have a study that shows, oh, there's no FOS, but we don't see that. We see it being very well tolerated by our patients. I mean, sometimes people get die-off, and sometimes people have sensitivity reactions. They just don't tolerate something. But I would say across the board, that's actually the herbal antibiotic that's the best tolerated.
It is the best tolerated. Okay.
The best tolerated. So basically, you don't have to be afraid that it's garlic. And so that's key. You're looking for like purified, stabilized allicin and not whole garlic. You don't want to see like garlic oil or whole garlic or aged garlic, anything like that in your products. And I think because this has become so popular, Now for SIBO, there are products that are labeling their whole garlic products and their garlic oil products as allicin because it does contain it in there.
Yeah.
But there are two brands that I know of that are more of this purified allicin. One is called Alimed. It's also sold under the name Alimax Pro. So that company is Alimax, and it has Alimax's lowest potency, Ali Ultra's middle, Alimed is top potency, highest potency, and then Alimax Pro is like Alimed. And by the way, the dose would be like 6 a day. And I believe I have these doses on my website. I hope I do.
You have it on your website under the
I hope so.
Okay.
Yeah.
And then I guess the follow-up question I had to that.
Oh, I just didn't mention the other product. It's NFH Allicin Sap. And so we've used those clinically, and I have no financial association with them.
Okay. Thank you for that.
Yeah.
The follow-up question I had too, so a lot of people I feel like are drawn to herbs because they think it doesn't have any adverse effect on the gut microbiome. It's not broad spectrum, where again, with some of these antibiotics, so metronidazole that you talked about, where it can be absorbed systemically and cause more potential damage to the bacteria that reside within us. You can correct me if I was wrong with that, but is there an issue with taking these natural herbs in terms of it disrupting the gut microbiome and the bacteria that are beneficial, or is it selective?
Well, I suppose it depends upon the researcher and the doctor that you talk to. I have certainly seen research showing that there are some of those herbs I just mentioned that absolutely disrupt the large intestine microbiome. But then I have colleagues that, focus their careers on this and vehemently deny that and don't believe that. And I don't really know who to believe. But I mean, I've certainly seen the Petri Mick plate results of, cinnamon and berberine are supposed to be quite detrimental to flora. So I don't think we can ever assume that herbs are generally better just because they're herbs or because they're natural. Like people can have, I've seen actually often worse reactions to herbs because I think they have so many components in them.
Yeah.
And that's not to say they're bad, but I think that's a bit of a naive approach. Like, from a medical perspective, I think we know that's not the case.
Yeah, I think too, as future NDers in the naturopathic field, that we're quick to kind of go to those herbs as opposed to pharmaceutical because it's more natural. I think a lot of people gravitate to us because they want that more natural approach where it's like really using everything in our toolkit, and something that you mentioned earlier too about how not just throwing the kitchen sink or throwing everything at that patient at one time, and just starting with a couple so that you can figure out what's working and what's not, because it kind of comes back to that principle of like the physician doing the least amount to intervene. And seeing, what we can do to support that self-healing process. And so it sounds like with SIBO though, like there does need to be some treatment. And so we have the elemental diet, we have the herbs, and we have the antibiotics. Is there something that would encourage someone to do an elemental diet more than like an herbal diet, or herbal antibiotics versus antibiotics? Is there one that you more commonly favor, and like how long would that treatment process be?
Yes, the thing that would encourage someone to choose one over the other would be to choose the elemental diet when they've been breath tested and they see that their gas levels are very, very high. Because elemental diet can bring gas levels down a whole lot in just 1-2 week course. I didn't mention how long these courses are. Pharmaceutical, antibiotics, and elemental diet, the typical course is 2 weeks or round, whereas herbals, it's 4 weeks. So it takes double the amount of time to get the same effect. That's fine though. But elemental diet can bring lower gas more than pharmaceutical or herbal antibiotics in 1-2 week course. So what I would call high gas is getting close to 100, and over 100 is severe. The test is positive for hydrogen when it's over 20, and for methane when it's over 3 actually, and over 10 in all cases. So when it's getting up towards 100, it's very high. And so pharmaceutical and herbal antibiotics on average bring gas levels down about 30 parts per million per treatment round. I mean, you see exceptions, but that's just an average, whereas elemental diet, it's more like 70 parts per million. So it has this great advantage, but it can be a difficult treatment because you are not eating during the treatment. You're taking this as your food, this drink. And that's sort of a form of a fast. And so you do need to be mentally prepared for that, and your family needs to be supportive, and you need to be ready to do that. So, but you get a big payoff.
Awesome. So if somebody had, let's say on a test, their gas levels were 90 parts per billion, per million.
Million.
They would need then 3 rounds of treatment if each round of treatment is decreasing the gas by 30 parts per million. Is that right?
Yeah. Okay. I got to get my calculator out and do it.
Right. 90 divided by 3, that's 30 if 30 is the average on each one.
Right. So if you may be able to get away with 2.5 rounds or something like that, because
that's important then, that if somebody, they maybe do 1 round of treatment, but they have a lot of gas and they don't necessarily get all the benefits, it's like, well, there's a lot of gas to treat, so it needs more than 1 treatment. So we can't just say this didn't work. We have to be a little bit more.
You need to know that exact information. And that's why the breath test is so vitally important. Because the key thing is if you hadn't tested and you were going by symptoms, which you can't actually diagnose the condition, but let's just say you were doing empiric treatment. It's something people do all the time and they're not bad for doing it. Then let's just say you gave a round of treatment and nothing much happened. You might be like, well, the person doesn't really have SIBO, when in fact, they might have very severe SIBO. They might have had 150 part per million gas, severe SIBO. And maybe you brought it down to 100 and you did amazing in that round. You would have no idea.
That's true.
So we often retest. That's what, so, let's hope you have the insurance coverage.
Yeah, absolutely. So one of the last things I want to talk about, because I talk a lot about food on my page. And so we also talked about food being a tool. 2-part question. Can you treat SIBO on its own through diet alone? And with a lot of these SIBO-based diets, what are some of those common cores of kind of like foods that they're eliminating, or kind of like what are the bases of those diets?
The basis of the diet is we're eliminating carbohydrates. Okay. And the reason for that, what's that?
It's the fibers. It's those.
It's more than just fiber. Fiber is one thing that's fermentable, but basically all aspects of carbohydrate are fermentable pretty much. So fiber is polysaccharide. And there's other types of polysaccharides like starch and resistant starch and mucopolysaccharides, which are things like that are in slippery elm and aloe and mucilaginous type herbs.
Which are beneficial to the gut. So if people are having gut issues and they're taking that, they may actually exacerbate symptoms. Is that right?
If they have SIBO.
Okay.
If you don't have SIBO, like if you have an ulcer and you don't have SIBO, that's like your best friend. If you have SIBO and you take it, it might not be your best friend. And that's actually one of the clinical hallmarks is when you give mucilaginous herbs to do healing in the gut because somebody's complaining of symptoms and they get drastically worse, you're like, this might be SIBO. So that's one of the keynotes actually. Starch is an interesting category. It is often tolerated by some, and then other people don't tolerate it. So these are things like foods like white rice, white potato, I mean, not sweet potato, and white bread, if gluten is tolerated, or even gluten-free bread. These are very starch heavy. And some people tolerate one form of these, but not another. And so people can't tolerate any starch. But those are the polysaccharides. We also have oligosaccharides, which are your classic prebiotics, the things like FOS and GOS, the things you see in probiotic supplements. That's a major category. Those oligosaccharides are in so many fruits and vegetables. This is what is responsible for beans causing farting and prunes causing diarrhea is the oligosaccharides. And then we have disaccharides like lactose. Many people are familiar with how lactose can be a problem for people. This is fermentable in SIBO. And then last we have the single sugars like fructose. Fructose intolerance has come into much greater awareness. So that can be an issue as well. So it's everything in a carbohydrate food that could potentially cause a problem. So these diets reduce carbohydrates, but your other question was really important. Can you cure or fundamentally treat SIBO with diet? And we have not seen that. Now, I have heard through the grapevine a couple, like 2 to 4 anecdotal reports, and this is after, I've been treating this for 10 years, since 2010, of people that just used diet and got all better. I suspect what was going on in those people is, which we haven't talked about this yet, is that they were the 1/3. So the statistics on SIBO are that 1/3 of cases are not chronic, meaning they don't relapse. You treat them, they get better, they're all better, and they don't relapse. 2/3 of cases are chronic. I suspect somebody that was cured by diet was in the 1/3 group. And so they just needed something to assist. And they were, the original cause was already gone. And usually what we find is we need something to lower that bacterial load. And maybe the diet was just enough. But it's so rare.
Mm.
What diet can do is control symptoms
Yeah.
really, really well. And it is an amazing tool for that. And people with chronic SIBO, which is a large amount of people, there are many underlying causes that we don't know how to cure yet. They need to use diet in their long-term management, reducing carbohydrates to some degree.
Amazing. So do you have resources on your website for a lot of these different diets and what people can explore, and foods that may be more triggering or may be helpful in palliating those symptoms in the meantime while they're kind of looking for more
Yes,
root cause?
yes, I have all the diets listed with links to all of them. Many, many years ago, it's like 2012 or something, I created a combination diet that took two of the diets,
Mm.
specific carbohydrate diet, SCD, and low FODMAP diet, smushed them together because they target opposite things. And that's called the SIBO specific food guide. That's all for free on my site. And so that's a very good list. It's graded by what's more likely to trigger, what's less likely to trigger. But a word of caution on these is that what a lot of SIBO patients do, they fall into, is extreme restriction because they are suffering. And so they're trying to control those symptoms with diet. And they go even more restricted than even any of these diets list. And so just as an example, all of these diets are like this, but as an example with mine, there's, columns of less fermentable, more fermentable. And patients will they'll only eat the foods from the less fermentable. And in fact, they'll only eat about, a fourth of those foods. So they'll restrict even further. And this isn't good. And it's not even, I understand why it's done, but it's not actually appropriate, because what we find is almost everybody, in fact, everybody, can tolerate some foods that are actually highly fermentable. Like I was mentioning garlic.
Yeah.
I was doing a webinar a month ago, and I asked people to say, is this true? I think there were like 600 people on the webinar. And I said, who has, basically raise your hand or let me know who can tolerate garlic. And it just started flooding in. So this is really, really important to know.
Yeah.
You don't want to assume you can't tolerate a food because it's in basically the no list or the more fermentable list. You use these diets as a place to start and as a guide, but try not to let your valid fear over the suffering that can come from foods detract you from trying things. And it's a difficult thing to navigate because, if you eat something that hits you wrong, gosh, what if you have to take off from work, or what if you're up all night or something? It's really a hard thing. So on that note, I do have a handout that's for free for everybody. You can get it on my website, SIBO Info on Resources Handouts. It's called Symptomatic Relief Suggestions. And just take a look at that. These are all drugstore items. Have some of them in your medicine cabinet when you're ready to try a food, and also only try a small amount. And then if it goes okay, in a day or two, try a larger amount. So that's the thing.
Amazing. So, you're so passionate about this, and you share all this free resources on your website, like you mentioned, because you really want to help people, because you've seen so many people and how much some of these people are suffering. So you've already gone ahead and actually put together a program where people that want to learn more specifically about SIBO, that maybe deal with SIBO, can learn more, but also for practitioners that really want to treat more gut specific, SIBO conditions and stuff like that, where they can learn more. Can you tell us a little bit more about that and where they can find that?
Oh, yeah. So the course for patients is called SIBO Recovery Roadmap. And I did it with a partner that we often work together. Her name is Siobhan Sarna, and she's a SIBO patient and advocate. By the way, I'm also a SIBO patient, which is where my passion comes from. I didn't mention that in the beginning. So, I suffered, and once I learned information, I thought, oh my God, this information isn't out there and I don't want others to suffer needlessly. So that's the patient course. And I believe you'll have the link down below. Yep. And we've got a coupon for your listeners and readers for that. And then the course for practitioners is called the SIBO Pro course. And that one is 23 hours. It's continuing medical education approved. And it goes into all the nitty-gritty and the details. Sometimes patients think, well, I want that one. And really the language is different and the whole approach is different. And really the patient course is also long enough. So I go into all the details you would need and have studies you can bring to your doctor and all that thing for the patient one. And for the practitioner one, it's just really detailed on everything you need to know to treat SIBO with very clinical, all your dosing charts and everything you need for the clinic, desk reference guide, etc. So
Cool.
those are those courses. And of course, there's my website that's all the time free for everybody.
Wealth of information. I want to thank you for your time. This is going to be so helpful for so many people. And, I really want to applaud you for, all of the, we talk about evidence-based medicine and, naturopathic medicine sometimes gets that bad rep about not always having that, the evidence support our claims. And you really do bring this really well-researched, evidence-based approach, which I want to applaud you for and thank you for, to really advance our profession and give people more knowledge that they can be advocates for their health, bring this information to their doctor. So it's true, patient-centered care, and they can really advocate on behalf of themselves. One final question that I wanted to ask you before we ended this was, is there something, you mentioned how you were a SIBO patient at one time. Is there something that you wish you knew that was kind of like this aha, like, I wish I knew this sooner and then it would have caused me way less suffering during your time dealing with SIBO that maybe we didn't touch on, or maybe you just want to re-emphasize that really was just like, I wish I knew this earlier during that time that I was dealing with this?
Yeah, I still have SIBO. I'm a chronic SIBO patient,
Okay.
just very well managed, so I live a happy life.
Good.
So, which is great. It's good to know that that's possible. Most people with chronic SIBO have their symptoms are reduced by 80% or more. So very good to know. I think it has to do with chronic SIBO, and it's more that I didn't even know that what I had was IBS. For most of my life, I've had basically IBS or SIBO since I was 5, and I'm 50, so it's a very long time now. And I struggled for so many years, always blaming myself, thinking I was doing something wrong, like I was eating the wrong food, or because I find that this often happens in mysterious diseases where the cause isn't known, like in IBS, is that it's blamed on the psychology, like it's all in your head, or, and it's blamed on personality, and we blame ourselves. If there's no obvious answer in front of us, we just think we're at fault somehow. So I thought there was something wrong with me in a way that wasn't medical. And I wish I had known sooner that there was actually, something like SIBO, basically, where it's like, this is caused by bacteria. So that is amazing for me. That was really, honestly, that was my biggest aha. It's deeper than that. There's the underlying causes. There's what's going on to allow the bacteria to be there. But I just think that was really the biggest aha for me. I have the constipation type. And I think many people know that can associate diarrhea coming from bacteria, because we know like antibiotics can cause that. Like they make your bacteria overgrow. It's called antibiotic-associated diarrhea. And then that, Clostridium difficile is a bacteria. All these bacteria can cause diarrhea. But many people don't know still that bacteria can cause constipation. And technically it's archaea and not bacteria, but that's a massive aha,
Wow. Well, I want to thank you for sharing your story, because I'm sure, there's healing, and I think sharing your story, but also the many people that also suffer with SIBO, and that there is something that you can do about it, because I think oftentimes too, conventional medicine will just be dismissive. Not that I think it's just more like they don't know yet that there are these options, and that there's more to look at. And so finding a doctor that will listen and advocate on your behalf, and you're giving so many people so many tools, and then giving people a place to start and giving them hope. So thank you.
Thank you so much for having me on and letting me tell everyone about it.
Yes, thank you. I will make sure to link the course at the end of this video on the YouTube page. This was a lot of fun, so thank you. And I'm so glad we're able to do this.